All right, everybody, we'll go ahead and get started. Thanks everyone for coming to this wonderful CPC we have today. For those of you who don't know me, I'm Harrison. I'm one of the chiefs. I'm primarily at the VA, but happy to be back seeing all of your wonderful faces today. And I just want to give a special welcome to all of the applicants who are on Zoom today. We have our first interview for our residency program today. It was really great meeting some of you earlier in the lounge. And we hope that this conference gives you a little flavor for our wonderful residency program. Before we get started, I'll just go through the one-liner. This is a case of a 26-year-old female with a past medical history of hypothyroidism who's presenting with chest pain and shortness of breath. We have our expert clinician, Dr. Josh Mitchell here, who I'll have him introduce himself in just a second. Before that, for the applicants who are on the call, I just want to do a brief introduction of what CPC is. So CPC was originally started around the year 1900. It traces back to Dr. William Osler at Johns Hopkins, where they started this format for medical education where they were trying to connect clinical reasoning with pathology or pathologic truth. Initially, this is where expert clinicians would be presented a case and they would reason through it, and then they would correlate their diagnosis with usually an autopsy to residents and students who were learning about the case and learning about how the expert clinician would reason through the case. This person on the left is Dr. George Dock. He was a mentee of William Osler, who came from Baltimore to St. Louis in 1910 and established this series of conferences here in St. Louis in 1910, and it's been evolving since then. The picture on the right is CPC happening in the residency program in 1953 in a former format called the pit, where the residents and students would learn from the expert faculty who are down in the bottom of the pit, kind of talking about the case and looking at the pathology. So it's a really cool format for learning that we have at our residency program, and it was always one of my favorite conferences every Friday when we did it. We have our expert clinician, Dr. Josh Mitchell, today, who is a cardio-oncologist. He is beloved by residents and fellows who get the chance to work with him. I had the privilege of working with him a few times during my residency, and I'll go ahead and let him introduce himself and talk a little bit about maybe what makes St. Louis and WashU a special place too.
Thanks. Yeah, it's good to see everybody. I hope you're enjoying the food. It looked pretty delicious outside. I grabbed a spring roll on the way in, which was, you do consulting for the major amyloid companies. This should be unrelated to this talk of a 26-year-old. The animation slightly off because I was going to go one at a time. So our one-liner was a shortness of breath in a 26-year-old, and she also had some chest pain. And so I was asked to maybe start off with a differential on shortness of breath. I certainly see it a lot as a cardiologist. When I talk to the patients too, I kind of just go through what we think about. And one is the problem with your lungs? Are we pulling in enough oxygen from the air? Are we delivering that oxygen to your red blood cells? So do we have a problem with the blood flow, which is the oxygen delivery? Or do we have a problem with the heart itself, which is why they're trying to see me, but it isn't always the heart, I will admit. Underneath cardiovascular disease, I'm going to ask, is it amyloid? Probably not in this case. They're 26, although AL amyloid is possible. I'm a cardio-oncologist, and so I might consider cancer medications, although you certainly can consider other ones. Also unlikely in this 26-year-old. Then you have your normal stuff. Are there blockages in the arteries of your heart? That usually is going to happen much later. It would be very rare for a 26-year-old. Is there heart failure? Is either the pump not squeezing well enough, or is it too stiff? Is there an arrhythmia going on? And usually that would only be in the case if they led with palpitations. It's unlikely if they haven't already given it to me in their one-liner, but I have to think about it. And then there's this group of other. And most commonly, at least in my clinic, a 6-year-old's coming to me with shortness of breath. A lot of it can be deconditioning. Unlikely again in this 26-year-old. It can be related to functional limitations. So if someone's having knee or hip issues, it's harder for them to do things. It's really important to think about sleep. Again, less likely in this particular case, but just if I'm looking up someone for shortness of breath, because I'll have people say, Dr. Mitchell, something's wrong with my heart. I just don't have the stamina I used to. I get short of breath really easily. And then you talk to them and they get like 4 hours of sleep and they had no idea that was impacting their quality of life. And so unless you ask questions about sleep, you're going to miss that. I would be surprised if this is a case of sleep apnea. It's probably not the first pick here to have for CPC, but I have to think about it, or things like chronic fatigue syndrome. And then, at least in cancer survivors, there's this kind of other layer where sometimes their cells can't process oxygen as well, and we may not pick it up on a heart test or a lung test, but their processing oxygen is not as efficient. But that would be a much less likely cause. So when I start to form my differential, I certainly use age as a main driver because there's a huge difference in what I'm thinking about in an 18-year-old versus a 60-year-old versus an 80-year-old. And here we have a 26-year-old, so I know that I can put amyloid much lower in my differential. AL is still possible, but unlikely. With a younger person, I'm going to be thinking about autoimmune diseases. I might think about spontaneous coronary artery dissection, which can happen in young females, although the median age is closer to 50, but it definitely is something that can hit a young woman when they're much less likely to have obstructive coronary disease. And then if they were having palpitations along with their shortness of breath or chest pain, then they may have an arrhythmia like WPW. I do note that the one-liner included hypothyroidism, and it may be a red herring, but it does make you start to go down the autoimmune path. One of the most common causes of hypothyroidism in a young woman would be Hashimoto's thyroiditis, which can also track with type 1 diabetes or maybe rheumatoid arthritis or lupus. Ultimately, I'm going to want more history. History helps out a ton. We can usually get the diagnosis in 70% or more cases by just listening, and it's also really easy to drive past. Sometimes I'll have someone in my clinic and they'll come to me and they'll say, hey, this person had syncope. Maybe we need to do a monitor. Maybe we need to do something else. And I'll be like, well, why did they pass out? Were they standing up? Did they trip? And they're like, oh, I didn't ask those questions. But that's huge. If I talk to someone and it's like a truly mechanical fall, I don't need to do $1 million workup. If someone's standing up and feeling dizzy, I'm going to focus on orthostasis as causes. So we really want history. Acuity for shortness of breath and chest pain are super helpful. Also associated symptoms. If I'm going down the autoimmune pathway, I might want to know if they have arthralgias or other things that might point me down there. But otherwise, are they just sick? A very common cause of shortness of breath and chest pain in a young woman would be bronchitis. Probably not the CPC for today, but certainly the leading differential. And so let's get some more information.
All right. Thank you so much for going through that and going through the way that you approach these common problems that you see every day and how the patient's information about them and kind of informs your differential. That's really what this is about. Before we go into more history, which I will give you, I'll go through my picks of the week. My first one is Miyu Thai on the right. It's, I think, the best Thai restaurant in St. Louis. It's in Webster Groves. I've probably been like 250 times since I've lived here. Highly recommend it. The Tower Grove Farmers Market is also my favorite farmers market. There's several in St. Louis, but I think Tower Grove is really awesome. And I highlight it here because there's only 2 more Saturdays left. It will stop on November 1st for the winter. So if you haven't had a chance to go, maybe for some of the new interns, I'd recommend trying to go the next couple weekends. And then on the bottom left is Summer's Gym. It's the WashU undergrad gym that all of the residents, if you're affiliated with WashU, you get a really discounted membership to, and there's basketball courts there. So if any of you guys are interested in playing basketball and want to use this gym, let me know because I go probably once a week. That's one of my picks. But we're here to learn about medicine. So we'll go back to the one-liner again. Like we talked about, a 26-year-old female with hypothyroidism who presents with chest pain and shortness of breath. And I'm going to go ahead and go into more of the HPI. So the patient said that she was started having chest pain around 6 months ago. She described that her pain started when she was 7 months pregnant with her first child. She described her pain occurring with minimal activity, almost always occurred with significant physical activity, and rarely occurred at rest. She described her pain as sharp on the left side of her chest and occasionally radiated to her left arm. And her pain was associated with shortness of breath. It stopped at the last 2 months of her pregnancy, and she ultimately underwent an uncomplicated C-section and had a healthy baby. And then about 2 months after her C-section, she started having the pain again. That's been increasing in frequency and intensity over the 6 weeks prior to presentation. And thus she presented to the ED for further evaluation. And I wonder, just kind of stopping there, based on your framework you presented, earlier with this history, kind of what you're thinking or how maybe you're narrowing.
Yeah, so here we're focused more on the chest pain, which I wondered getting the one-liner, although I was asked by the person who emailed me to focus on shortness of breath. But here we're focusing more that chest pain is a big driver of what's going on. And it's amazing sometimes when you don't get the information that you need from a history, how that can affect patient management. And although I don't necessarily jump on obstructive coronary disease in this person, still we have some other things on the differential. It does remind me of a patient who was in his mid to late 30s, and he was following up from cancer, but is probably not cancer related. But he says, I'm coming to you because I've been having chest pain, and I got a full GI workup. I just had a scope. They didn't find anything, and so they just recommended I go see a cardiologist to see what might be happening. I've just been having a lot of heartburn. I was like, oh, you're having heartburn? He said, yeah, I'm having a lot of heartburn. It's like, is this after you eat? No, I don't have any heartburn after I eat. I was like, well, when are you having the heartburn? Well, whenever I exercise. And and I was like, well, describe that heartburn to me. And he's like, well, I get this bad chest pressure and I get short of breath. And if I stop exercising, I get better. I was like, oh, so you're describing typical angina that we've given you an EGD for, which was normal. And he had a completely occluded LAD when we did his workup. And so even though it's always lower on the differential, it can happen. And so here we have typical angina. It's worse with exertion, better at rest. The differential, again, in a younger person is a little broader than obstructive coronary disease. So I'm thinking, again, things like spontaneous artery dissection. In this case, it's not acute, but is it subacute? You're thinking even things like Kawasaki's disease or other things that she have like vascular aneurysms. But you still think of potentially obstructive coronary disease, even though it would be much less likely. Still very low, but I just don't want to miss those types of things. And I think, we've all learned as we approach differentials, we want to do common, and that's going to be the right 99% of the time. But we think about the uncommon or more serious. And so going in, I'm definitely getting typical angina. And when I'm hearing typical angina, I'm certainly thinking that it could be cardiac, which my index of suspicion was already high since Harrison invited me today. But I'm definitely thinking more cardiac with the typical symptoms.
Okay. Well, thanks for going through that and kind of how the history is so important, particularly in a patient with chest pain and determining whether they have typical cardiac chest pain or not. I'll give you a little bit more information about this patient. So like we said, past medical history of hypothyroidism, just the C-section is the only surgical history that was just a few months prior to presentation. She has a family history of a first cousin with a cancer of unknown type in his 30s. It was a male cousin. And then no family history reported of cardiac disease, sudden cardiac death that the patient can remember or knows. No allergies reported. She's just on Synthroid 50 micrograms daily. She's currently living in St. Charles with her husband and isn't currently working and has no history of tobacco use, alcohol use, or any substance use. So you mentioned this a little earlier, but kind of thinking about your review of systems, would there be anything else that you'd be asking this patient particularly to maybe rule in or rule out some things that you're considering?
Sure. So, timeline, we mentioned acuity's helpful. So with 6 months, I'm not thinking acute pneumonia, but I definitely should be asking that. I mean, you could still have subacute disease. And so I'd like to know fevers and chills and night sweats and those types of things. I'd ask about palpitations. Again, less likely now that we know it's with exertion, it's less likely to be randomly associated with an arrhythmia. So my arrhythmia is going lower on my differential. Because she is a young woman, I'm still worried about autoimmune disease, then I would certainly do a more full review of systems for things like lupus to include arthralgias, arthritis, and those types of things. And certainly in those types of cases, as we know, that's a multi-system disorder. We really do want a full review of systems when we do that. We don't just want to say, oh, the system's reviewed negative, as sometimes we learn to do just to do the notes. We do want to get a more complete review.
Okay. We'll go ahead and go to the review systems then. So this patient denied any chills, fever, weight loss, really just positive for dyspnea on exertion that was associated with this sharp left-sided chest pain that occasionally radiated to her left arm again. No palpitations, no lower extremity edema, no orthopnea, paroxysmal nocturnal dyspnea. Otherwise, pretty much unremarkable, specifically for arthralgias or joint pain, like you mentioned earlier, and no rashes either.
Now, can you tell me where on her chest it was hurt?
So left side. I obviously didn't see this patient, but that's how it was described, kind of on the left side of the chest.
So some of it's artificial. I'm in a CPC, and it's more likely going to be cardiology. But at least when I'm seeing a patient, the location can be helpful. It's not ever 100%. We never in medicine, everything's probability. And so when someone comes in with chest pain in the ER, it's like a 30% chance they have cardiac disease. But you're always asking yourself things to go up or go down. And so if someone has more obstructive coronary artery disease, as an example, it's usually a chest pressure in the middle of their chest that may or may not radiate to their jaw or their arm. The more lateral it gets, the less likely it's the heart. If it's like actually truly sharp, the less likely it is their heart. So these things can inform us, but we should never rely only on them. As we also learn, sometimes women present with different types of symptoms, and sometimes it's because they're just negating their feelings. And so another quick story is this lady who said, I get chest pain, but it's only with anxiety. I think it's panic attacks. And I said, oh, okay, great. When you get this anxiety? Every time I walk up the stairs. And so again, typical angina. So we have to ask those questions to help us. But it would be nice to know exactly where it is. But I'll certainly accept that it may be cardiac related.
You kind of already went through your additional thoughts. So we're going to give you the physical exam next, but I wonder if there's anything in particular you'd be looking for doing any maneuvers on physical exam.
Sure. So things that are possible, especially if it's less typical, but still heart related, might be, a pericarditis, pericardic effusion. That usually is worse with lying down and getting better when sitting up, though. So that's unlikely, but we can listen for those types of things or listen to pericardial revs. Sorry, I blanked for a second. On the review of systems, it's less likely that she's having arthritis or anything like that, but you can look for those types of things. Mainly, I just want to get good pulses. I'd probably get good bilateral blood pressures since we're worried about vascular disease.
Sure. So I'll go ahead and give you the exam. So blood pressure 102/62, which on chart review of this patient you'd see is about at her baseline. A heart rate of 115, which is not at her baseline. A respiratory rate of 14. She's satting 97% on 2 liters. And in the notes, it sounded like she was having some occasional desaturations, which is why the oxygen was placed. Afebrile and then a BMI of 27. General review, she looks like she's in no acute distress. She's conversant with you. Her notable cardiovascular exam, she's tachycardic but has a regular rhythm with a normal S1, S2. No audible murmurs, rubs, or gallops. You examined for JVD at 45 degrees and don't see any, and you don't notice any lower extremity edema or any unilateral swelling or redness of her legs either. And then a normal pulmonary exam and otherwise benign physical exam.
Sure. So thanks. And so I guess I'll at least reassert, when we're evaluating a patient and we're worried about cardiac issues, especially heart failure, then we certainly want to do a good volume of SAM. That's very helpful. And so knowing if they have swelling or not. All patients don't have swelling. About 30% in one series had swelling when they were in heart failure, like 50% had abdominal bloating. But the rest you'd pick up with a JVP or JVD evaluation. And so it's always great to develop that skill if you haven't already and to practice it. So having a normal one, though, really tells us that she has a normal pressure in the right side of her heart. And so if she's in heart failure, she would be low cardiac output, but that's not really on the top of our differential. We're looking for signs of chest pain.
I'll go ahead and give you some initial labs that were done in the emergency department.
And is she currently having chest pain or not currently having chest pain?
Not currently.
Okay.
So here's CMP. Go ahead and let everyone review. Here's a CBC. And then some other rapid tests that were done pretty quickly. You didn't specifically ask for them, but beta HCG and TSH was also performed as well. I wonder if this informs you at all.
Sure. It helps me know that she's not pregnant, and that's good. So far we have a relatively negative lab workup, and so we haven't really helped. It doesn't necessarily affect our main parts of the differential. Our main part of the differential was that there may be some coronary vasculature. In the main part of the differential may be too strong of a term because there's still a lot of things that could be, but at least from a cardiac, what I'd be worried about standpoint, I worried about coronary arteries, and in this case, I would have expected it to potentially be all normal. But it does help me continue to drive lower down something like lupus. I'm not seeing abnormalities on the CBC.
Yep.
It does show me that her thyroid may not be fully controlled, and so we need to follow up on that. But that's probably not the sole driver of her chest pain. I would want to get an EKG with everything that's been going on, which will probably be one of the sooner slides. And then it would be nice to, with her cardiac symptoms, to have an NT-pro and a troponin.
Okay. And normal diff. Okay, so we'll go ahead then. If you would like to get an EKG first, we can go ahead and go there.
I'll get whatever your next slide is first.
Here's your NT-pro and a troponin.
Okay.
You can go to A1C.
So the NT-pro is not a perfect test, but it's a good test. And having a normal NT-pro really does have good negative predictive value for heart failure. NT-pro notably can go up in kidney disease and sepsis. And so there are other reasons it may be high just to be aware of as you go through your training. Troponin really shows that we're not having any active myonecrosis. There's no active myocardial death. It does not necessarily mean the patient doesn't have an obstruction if it's not causing myocardial necrosis. And then her A1C is pretty normal. So we can take type 1 diabetes off the table.
That's right. I will go ahead and give you an EKG next.
So looking at the EKG, there's certain things that we certainly want to look for. If we're looking for badness, we want to make sure there's no ST elevation. We don't see any tombstoning, which is good. And if we're looking for badness, then often we'll have widening of the QRS. And so we can kind of pick that up just getting the overall gestalt of the EKG. But looking at it a little bit more closely, we see that it's a regular rhythm. There is a P wave before QRS in a predictable manner. And so it does look like normal sinus rhythm. Technically, you can't tell the difference between an atrial rhythm and a normal sinus rhythm if the atrial driver is close to the sinus node. But otherwise, it's unremarkable as far as the origin of the P wave is concerned. We do have an RSR prime in V1 and V2, which is a fairly normal variant, so we wouldn't consider that pathologic. Non-specific T wave change in V1, but that's also pretty reasonable. So no major abnormalities on the EKG other than the tachycardia.
Okay. So I think now, where would you go from here? Considering your differentials, this 26-year-old with chest pain that sounds relatively typical for cardiac chest pain with a normal troponin and relatively normal EKG.
Yeah.
What does next? Yeah.
So she's on oxygen, so I'd certainly want a chest X-ray. It's unusual, it happens, but unusual for purely cardiac pathology to give you an oxygen need. And so we always think about lung pathology in that case. And then we have someone with more typical anginal symptoms. In most cases, when someone's young, we don't do the invasive tests. We do the non-invasive tests if we can, and that might even include like a CT coronary if you want to get a coronary evaluation for her. If you're really worried about acute spontaneous coronary artery dissection or SCAD, then it is recommended that you do an invasive coronary angiogram because you might miss it on a CT coronary because some of the things that you're looking for in SCAD are like blushing with the contrast injection. And so some of that's best teased out with the patient in front of you and trying to decide how acute she is or how non-acute she is. But I certainly would want to get a chest X-ray and then consider if we aren't seeing any obvious other causes from a lung pathology standpoint, what type of coronary evaluation we might do. Okay. The other things on the differential with, acute shortness of breath are going to be things like pulmonary embolism. And so we can also consider that as far as how we do our testing.
Okay. Would you accept a CTPE?
I would.
As an initial image? Okay. So we will go there, and I will call up Dr. Kim to go through some images for us.
All right, so this was a CTA chest done per pulmonary embolism protocol. There was no pulmonary embolism on the study. We do, however, have this enhancing and hypervascular soft tissue mass that's centered in the left atrioventricular groove. It encases the left coronary artery and its branches, and this mass extends along the left aspect of the mediastinum, so you can see it extending along the main pulmonary artery there, and then also extends along the left ventricle. It's large overall. It measures about 10 by 9 by 7 centimeters. And then also relevant whenever we have a mass, we're thinking, could it be a neoplasm? Could it be a malignancy specifically? So we look for evidence of metastatic disease. We did not find any, so nothing like pulmonary nodules, thoracic lymphadenopathy, no pleural effusion, no pericardial effusion, or nodularity of the pleura or pericardium, no bone lesions concerning for Mets, things like that. And then the lungs were clear.
Thank you.
Okay, so we've identified a problem.
We have identified a problem. And so did you say that the mass was encasing a coronary artery or not encasing a coronary? Okay. And so this should normally be low on your differential, but certainly possible for it to happen. In the back of my mind, I wondered if we'd have a curveball like that, but I didn't want to beat this too early.
Sorry.
But either way, that's why we do these tests, and we usually start out with the less invasive, the easiest test first, and also depending on how acute we are. So knowing the patient's not actively having chest pain and knowing they don't have troponin, and they don't have an ST changes, we don't have to go straight to the cath lab, and we can sit back and do some tests. CT is going to be your best test, and a lot of times for picking up a tumor, because it has the best spatial resolution. A lot of times we think about MRIs because it has the best tissue kind of differentiation, but a CT has the best spatial if it's a CTP or something else with thin slices. And so here we have a left atrial mass. When we see a mass in the left atrium, if it's a cancer, then it's more likely to not be a primary cancer. It's usually from somewhere else in the body. And so if it's a primary cardiac, it's lower on the differential. And then once we have a primary cardiac, we have both benign and invasive types of tumors. And so we're thinking about all those types of differentials. Sometimes we get a lot of information just from the CT scan. We don't necessarily need another imaging test. Usually the automatic thing to do, though, is to get a cardiac MRI to better understand the tissue that's involved. And if we can make more of a diagnosis between the CT and MRI, then we don't always need to do a biopsy. Because it's a left-sided tumor, we're worried about, you said left atrium, correct? Okay. We're also worried about anything where there's like tumor thrombus, where it could embolize and cause a stroke. And so there's always a higher urgency to removing a left-sided tumor if we can, if there's no signs of metastases, and there wasn't any metastases or other things. We're dealing with a solitary tumor. There are some tumors, like the left ventricular HAV group, that may just be able to sit there, like a paraganglioma. I typically see them in older individuals, but sometimes they're very stable. They're entwined in all the vasculature. And as long as the patient feels well, then you don't want to do a major surgery. In this case, though, we're already having chest pain, so we're having symptoms, and we're probably leaning towards considering removal in that case. Okay. So I don't know, did we do a cardiac MRI?
We did.
Okay.
We did other cardiac testing as well.
Okay.
I'm curious if there would be, besides a cardiac MRI, if there's anything else you'd want to know from a biopsy or surgical planning standpoint.
Sure. So, fortunately, at a place like WashU, we can get it all done. And it is really nice. Sometimes I take that for granted, especially when I talk to someone else and they can't get a biopsy or anything like that intravascularly. But from a planning purpose, an MRI would be nice, which can also give me an ejection fraction. I expect it to be normal, but it's nice. An echo can also give me that information, but if I'm going to get an MRI anyways, I don't necessarily need the echo. From a surgical planning standpoint, we usually get PFTs and carotid Dopplers, but it's unlikely to have an abnormality at this age. Some people may or may not argue for like a CT coronary or a cardiac cath, and depending on what information you do or don't have, if you need to better understand the relationship to vasculature, you could. But on a CT-PE, I could probably see a decent amount. It just kind of depends on the actual cuts and how I'm lining things up, whether I need more information from a cath or a CT coronary. Does that answer your question?
Yes, it does. And I'll tell you, this patient was seen here, and all of those tests were pursued. So just for the sake of the audience, I'll kind of go through them in the order in which they were obtained. And so this is an echo that was obtained.
And so echoes, even if I'm getting the MRI, sometimes it's helpful for a certain patient to get the echo anyways, because I cannot usually get that same day or at least the very next day. MRIs are sometimes a delay. I'll at least throw out for the audience, for the residents, that if you need an MRI urgently, the MRI team is usually helpful. And I usually get that if I'm worried about immunotherapy-associated myocarditis. And so, again, saying I'm blessed to be at WashU, different case. But I was worried about immunotherapy-associated myocarditis, and within 24 hours, I had a biopsy and an MRI done overnight. And I was like, oh, this is so great. But the echoes are faster to obtain. And so we see here the mass on the left side of your screen. A lot of it does seem external to the heart, and impinging kind of, depending on the view, on the left ventricle and left atrium. It's hard to tell if there's anything that's intracardiac on this particular view, although the CT would be really helpful, and we already have that CT as far as seeing exactly where it's located at. But these echo images would suggest that they're external to the heart.
Okay. And then the team that was taking care of this patient was interested in the blood supply of the tumor, and so they did pursue cardiac cath. And so I have some of those images to show you as well.
So for those of you in the audience who don't do cardiac cath on a regular basis, can you play the right coronary artery on the bottom left? So this is the right coronary artery, and that's what you mostly expect until the very end. You see blushing in the tumor. But for mostly, you just see the outline of the coronary arteries as they go around. But then as you wait, you start to see the blushing. And waiting is usually when we see collaterals too, if we're worried about an obstruction. But when we inject the left coronary artery, which is the bigger image, we see definite communications. And so thinking in your head that you should be seeing more of that bottom left image where you see these discrete blood vessels and you don't see all this extra stuff. Now on the left coronary artery, we're seeing all of this extra stuff, both on the bottom part of the picture and on the top part of the picture. So you really are seeing a lot of supply of blood flow to the tumor directly from the coronary arteries.
And the kind of read on this image was that there was a significant tumor blush on the left coronary injection with extrinsic compression of the left main LAD and circumflex with coronary steal phenomenon with shunting to the tumor. I wonder, before we go to the cardiac MRI, based on your differential of what the tumor could be, is there any biochemical laboratory workup that you would do to try and narrow your differential?
Not off the top of my head, okay. But the nice thing is I can call a friend at WashU. I mean, when we think of tumors in the mediastinal area, then we certainly have a relatively broad differential. I don't know off the top of my head what's most likely to have coronary steal in that case, but can look it up. But as far as tumor markers for those, I'm not familiar with those.
Okay. We'll go ahead and go then to the cardiac MRI and have Dr. Kim come back up. Right.
Right, so we have some cardiac MRI images. Once again, we see this large soft tissue mass that's centered in the left atrioventricular groove that extends along the left aspect of the mediastinum and the left ventricle. We already saw on the cath images that it's a very vascular tumor, and so not surprisingly, this mass enhances avidly. You can see that on the bottom three images on the slide. Those are the post-contrast images. So avidly enhancing vascular mass. It does result in some mild mass effect on the adjacent cardiovascular structures like the main PA, but there's no evidence of invasion of any of these structures. And then, as we already mentioned, the mass encases the left coronary artery. And then the atria and ventricles are normal in size. And then when we calculate the ejection fraction, the RV and LV EFs were normal. So based on the location of this mass, based on its imaging characteristics, the differential diagnosis that we provided for this mass was paraganglioma, lymphoma, some kind of atypical manifestation of a mediastinal hemangioma. And then sarcoma is included in the differential, but considered less likely due to the lack of invasion.
So as far as the differential, including the paraganglioma, you can look for markers of a secretory paraganglioma, which you may have been going for, versus the others. And if you have a secretory paraganglioma, that may help you differentiate. You can also sometimes do special nuclear testing with a tracer to help identify paraganglioma better. And I'm blanking on the actual tracer that's used, but luckily I can search Google for it really fast. And so those would be considerations. And if you can't make the diagnosis based on that, then you may consider whether you need to do biopsy or not. Certainly, it's a more complicated procedure because we do see that there's a lot of blood flow to it from the coronaries. And so it would be a discussion with surgery on what's feasible or not feasible. Your other options are radiation or potentially chemotherapy, but you certainly want a diagnosis as far as what are we targeting. And so we need to know what tissue we're targeting.
Right. So I guess next steps for you, if you were taking care of this patient or a consult on this patient, you would involve cardiac surgery and see the feasibility of her biopsy and then discussion around potential removal given the patient's symptoms.
Yes. What I would do at this particular stage is I would have a discussion with radiology to hone in on that, although we already got a really good update from them on what the differential is. I would look up biomarkers or things to do if I could try to hone that down, like what can I do to confirm if it's a paraganglioma or not, including nuclear tracers, and what we need to do to hone that differential, and then consider whether we can do a biopsy or not to drive the next decision as far as removal. And once we have the biopsy and we know what the pathology is, then we can discuss the options for what to do with it, which would include radiation, surgery, or potentially chemotherapy. When we have a solitary mass, we really like to remove it when we can, but we have to weigh that against the risks of the surgery.
Okay. Thank you for going through that. The team that was taking care of this patient, they did those things and they consulted cardiac surgery here who felt that the tumor was not safe to biopsy and felt that it was best to proceed directly with surgery. They did do some biochemical testing, like you were mentioning, specifically testing for secretory paraganglioma, where they tested for serum fractionated free metanephrines and norepinephrines and urine free metanephrines and norepinephrines and chromogranin A. All this testing was normal. And so they had an idea of what they thought was their leading differential of this tumor, and this patient ultimately went to the OR. And so minimal other kind of diagnostic testing was done. So I think we'll go to the diagnosis and then kind of go to next steps and what the pathology showed from the OR. But if you had to guess what you think this tumor is, what do you think?
I will go with lymphoma.
Okay. So we'll kind of walk through what happened next. So this was a cardiac paraganglioma that was non-secretory. So You were so close. And you mentioned it earlier. But this was a really complex case. So oncology, cardiac surgery were all involved in this patient's care. Again, they deemed this not safe for biopsy given the vascular supply of the tumor and location, and ultimately planned for surgical resection. There's a surgeon, I guess, in Houston who does this particular surgery and resects cardiac paraganglioma. So this patient was actually sent there and underwent a 3-vessel cabbage with resection of the mass, and pathology from the OR was consistent with paraganglioma. And then the patient ended up following up with cardiology in 2023 with a repeat cardiac MRI showing normal cardiac structure and function and no evidence of recurrence. But this was a difficult case, and we certainly appreciate you going through your clinical reasoning and learned a bunch about approach to cardiac mass and chest pain and shortness of breath and how to kind of narrow your differential. So if we all can give a hand for Dr. Mitchell. And I just have one teaching slide on paragangliomas. They're neuroendocrine tumors that arise from extra-adrenal chromaffin cells that are derived from the neural crest, which can occur anywhere along the sympathetic or parasympathetic chains. They commonly do present with the triad of headache, palpitations, and sweating, which you may see with a PHIO. You can just think of a paraganglioma as a PHIO that's not in the adrenal glands. And they may be functional or non-functional. This patient's was non-functional, and those are often found in the head, neck, and around the heart. About 40% are associated with genetic syndromes like MEN2, von Hippel-Lindau, and neurofibromatosis type 1. And usually when patients are diagnosed at a younger age or in an unusual location like this, they would be more likely associated with a genetic syndrome. And usually you need either imaging findings consistent with the tumor morphology or the secretory nature of it with the metanephrin testing. And almost always you're going to do surgical resection. If it's secretory, then you need the preoperative alpha and beta blockade. But again, that's all I got for my teaching points. Thank you again so much for coming, and for the applicants that were on. I hope you learned a lot from this and took something away from CPC. And thank you so much again for being here.
Great case.
Yeah.